So, hi, Hannah, welcome.
Hi, Millie. Lovely to
Hi,
see you.
it's amazing to see you. We last saw each other in, I think it was 2018. Was it
Mm,
2018 or 2017?
I've lost track, but I know it was Sydney and we had a lovely day walking around the
Yeah,
harbour.
yeah, we had a lovely time. That was an amazing adventure for me to go all the way to Australia.
Mm.
And thank you for your continued amazing work as an advocate for women in childbirth. You're an absolute powerhouse, and it's amazing to have you here on the podcast today. Tell me a bit about what you're up to at the moment and where your thinking is at.
Look, I'm involved in lots of different research projects, and I have a lot of PhD and masters and honours students who are also leading really interesting projects. But in the last sort of 5 or 6 years, really, based on a lot of work we were doing around things like free birth and why women are moving outside of the system due to traumatic births. And we, of course, published a book in 2020 called, the Birthing Outside the System, the Canary in the Coal Mine, which was all that international research on it. I've really moved more and more into the interest in birth trauma and in models of care and what can we do to prevent up to 30% of women walking away from their births feeling like they have been in a war zone. And, the implications that has, we've been chasing the ripples, the implications on the baby, on the partner, on the family, on the future is mega. And yet birth trauma is still a dirty little secret that is really only now having the lid and, the lid lifted, and we're really trying to be part of that.
Yes, because I think women are so encouraged not to talk about their birth trauma and, almost made to feel like that might be a selfish act to think about their own experience in the birth room.
And you've got a healthy baby. Why are you complaining?
Yeah.
And unless you have a significant damage or scar, people do not understand that the majority of birth trauma is psychological, and that psychology is really important to healthy mothering and healthy womanhood and healthy families and healthy society. So we need to move away from trauma just being about physical trauma, which of course is vitally important and often is co-located or occurs with psychological trauma. But women can have no physical trauma and be utterly devastated by the birth experiences they've had.
Mm. Let's talk a little bit about just unpicking everything you said, which is already amazing. Let's go back to what you said about the canary in the coal mine and women who birth outside the system. That was something I became quite fascinated with as well when writing Give Birth Like a Feminist. And as you probably know, there's a chapter in there called Loose Women, which is kind of about exactly that, about the women who can't be tamed, can't be controlled. And that goes for midwives as well as women, pregnant women, because they also get punished for trying to think outside the box. So could you talk a little bit about that?
Yes, and actually in the book we have a few chapters actually dedicated to that. And basically the system is crushing anyone who does not comply with norms of the system. And if you become an ally for women, which midwives are often the closest ally to women in the maternity sector, and then you think midwives are often low in the rung of the very powerful health services that we have run, which are financial, managed, and doctors have an enormous amount of power and say and influence. You then know how easy it is to target that already, first of all, vulnerable group of women going through this intimate, vulnerable experience where they need trust and relationships, and then this group of midwives that are still struggling for identity and for recognition and for respect. So you put those two together, and man, they love lighting the pyre under women, and particularly midwives who support them.
Yeah. So the women who want to birth outside the system, who you've written about in your book, tell me a little bit about them and their motivations. What are they saying?
So the book is like a collection of many, many different studies. About 6 of them are ours, and then we have them from all around the world. And whether it was a story from India, whether it was a story from the Netherlands, whether it was a story from the UK, whatever country we had the stories from, and these were research-based chapters, They've a very similar principles. And the first principle is that most women who choose to free birth have got trauma. So they usually, the majority, have had a very traumatic birth experience where they have often been disrespected, coerced, they've come out devastated. You know, a certain amount of them have post-traumatic stress disorder, which is, of course, the very serious pointy end of birth trauma. And we've interviewed women who've said, I can't even look at a hospital sign or even hear an ambulance without breaking out in sweat and feeling sick. So these women almost couldn't darken the doors of a hospital if they were, you know, triggered by it. But also their previous experience meant, sadly, they didn't trust anyone in the health service, including midwives, which is really heartbreaking. And they saw midwives in their cases as often aligned to the system and cooperating with the system that led to their trauma. So they choose to go outside the system. They choose to birth at home. They choose to birth unattended by a professionally trained midwife. Some, increasingly on Australia, unregulated birth workers are being employed, or doulas, or they just do it themselves with their partner. And really they're responding to what we've done to them in the system. So when we point our fingers at these women and say, you know, these are selfish, dangerous women, actually, we are the cause of that. So what have we done? Have we failed our job so badly that they don't want what we've got to offer? So that's really the heart of free birth.
There is so much woman blaming in all running through all of these situations, isn't there? I often talk about the woman blaming that happens after birth trauma, because I find it's sometimes women who have a plan, who have a hope for what kind of birth they might want. Maybe they plan a home birth, or they want a water birth in hospital, or they do hypnobirthing. And often they're sort of made to feel like that if they hadn't got their hopes up, they wouldn't be feeling this way. That it's not the system's fault for damaging them, for traumatizing them, that it's their fault for thinking that they could have had a positive experience.
And you see, they've looked at the evidence and they do know that's possible. And if they don't know about different models of care and the fact that you can walk into all these different models of care and statistically we can tell you what your birth rate outcomes will be, they don't have that information. So they often walk in, they go in Australia, they go to see the GP. If they've got private insurance, they go see the private obstetrician, or they go to the local public hospital. They don't know about midwifery models of care. They don't know about all of the options. And it's not till they're well and truly stuck in a system and they're on that ride where it's almost too late often for many of them, that they suddenly think, oh my goodness, I really had no idea.
Yeah. And yeah, it's women are being so let down. I do want to come to a more sort of solution focused conversation, but just before that, just can you talk a little bit about your a recent paper that you were involved in about obstetric violence?
Sure. So I just want to really point out that my wonderful PhD student who finished last year and is now an early career researcher led this paper, and she and I are leading the BEST study, which is the birth experience study in Australia. And we sent out a survey which went across Australia, and we got over 8,800 women who completed this survey, largest survey ever done in Australia. And rather than all the sort of standard survey questions that lots of satisfaction surveys or health service surveys asked, because we'd already been working on the BITOC study, which is the birthing time of COVID, we developed lots of wonderful questions. And so we embedded in that questions around birth trauma or obstetric violence, models of care, and a lot of open comment opportunities. So women left us thousands and thousands and thousands of comments. I mean, one of the papers we've got under review now, the 6,000 comments that we have analyzed. Women they care about their births, they care about the care they get, and they care about other women also getting quality care.
Yeah.
So
it's such a massive
paper.
It's a massive experience in women's lives, and it's so often underestimated that the impact and the way that the memories of it, good or bad, stay with you forever. You talked about the ripples when we were at the beginning. You were saying about how the experience ripples out, and I often think that when we talk about the healthy baby, and health, and we really reduce health down to just this idea of being alive, having a pulse, being alive.
Yes.
Whereas health is so much more complex than that, isn't it? And the ripples of that experience go out into a woman's future life and her baby and her partner and her close community everywhere.
Absolutely. And that's really important. We're so focused on, is the mother and the baby alive or damaged? And that seems to be where we think our job ends in the health services. But, that's a tiny part of this picture. What about, cultural safety, emotional safety, spiritual safety, psychological safety? Why are those things not important? Because they really are to women.
Yeah, and also the flip side, I always think it's interesting when you talk to women who have had really incredible birth experiences, which is really, really rare. It's hard to find women who've had absolutely brilliant birth experiences where they feel they birthed their baby under their own steam. The midwife was there probably, but just sat on her hands, and they felt that power of their body, and they did it. They chose what to do. They were completely autonomous. It's so rare to find these women, but when you talk to them, it's like something's happened to them. It's like a milestone in their life that transformed them, and they take that forward. So, as well as talking about just women not being traumatized, I think it's really, I'm interested as well in thinking about why are we not I hate using the word allowing, but what is holding us back from enabling that situation where women can have those birth experiences that change their life, that make them feel like there's nothing that they can't face for the rest of their life. They will feel a stronger woman because of it.
Absolutely. Why do we not think? I mean, this is the Everest that women get to climb. This is the life experience of climbing Everest and achieving this amazing thing that men can't achieve. They certainly can be the fathers, and they can certainly be wonderful partners, but women give birth. And it is phenomenally amazing. I mean, if I said to you and you were getting married and you were planning a wedding and that, it really doesn't matter. Weddings don't matter. It doesn't matter how it turns out. It doesn't matter who you invite. It doesn't matter who crashes it, or whether there's drunks at your wedding, or whether they pull down the wedding tent or what. It doesn't matter. We would go, we'd be horrified. But it doesn't matter that strangers barge into your birth room while your legs are open. It doesn't matter that people roll their eyes at you, that you're given no choice. Like, how dare we?
Yeah. And those were some of the sort of shocking situations that you uncovered in this research you've just been involved in. Was it something like 10% of women?
Yeah, 10%. Over 1 in 10 women reported disrespectful or abusive care, which is defined as obstetric violence. Nearly a third of women have birth trauma. But we looked in this paper that was published, led by my wonderful colleague Hazel Keedle. We looked at women who answered yes to the obstetric violence question, and then we looked at all the comments that they made in what was it that was done to them. And, we found that of those 8,804 women, one of the biggest categories was this disrespect, abuse, and coercive comments. But really worrying, 7% were about physical abuse. And this is in Australia. We're a supposedly liberated, good country for women to live in. And 17% were trauma and violence, being held down for vaginal examinations. And some of the stories, when you read them, it's like them describing a rape scene. So the devastation in their lives, and of course that put them at much higher risk of birth trauma as well. These women are less likely to want to go on and have another baby. And if a woman has past trauma, so if she's had a sexual abuse history, she's got mental health problems, if she's had a major health event and felt distrust of people from that, and then this happens to her, it's almost like, right, that's it. I've proved I can't, I'm not safe. And it's one of the most ultimate betrayals, because we all think when we go to see health providers and we put our lives in their hands, so to speak, though we should always say, no, it's our choice, and we ask, they work for us, we would expect the best from them. And we would expect kindness, compassion, respect, consent, all the basics. And unfortunately, women are not getting that.
Do you have a sense of what's happening on the other side in terms of, because I always find this a really interesting paradox that you have healthcare providers who will tell you this isn't happening. It's kind of a little bit like, sexual harassment, I suppose, isn't it? You know, you have men who say, well, I don't do that kind of thing, and none of my friends do. And then you have women who say, this happened to me. So I don't want to compare healthcare providers with sexually abusive males, but it does strike me as that's something going on here in terms of what are healthcare providers thinking they are doing when that woman is having that experience that she's described to you.
Well, it's very akin to that because they're in a position of power and trust. So if you look at, abuse of women, you look at pedophilia, a whole bunch of things, which I'm not saying is the same as what we're talking about. The abuse of power and trust lay at the heart of what's going on. So that's kind of the really first, important thing to think about. We are also, I have a wonderful master's student who's just finished her master's looking at midwives' experiences of obstetric violence. So we know a lot now from women's experiences. We're getting worldwide research, particularly in many of the low and middle income countries. But, the high income countries have kind of gone, we don't have that problem. So this is the first time we've kind of lifted that lid on, man, have we got a problem. But with obstetric violence, it's a really tricky topic. So I want to make really clear, we're not talking about only obstetricians, and we're not talking about only men. We are talking about health providers in positions of power and trust within the health service that are violating that. So these are midwives too. So there are certainly midwives who have done this. So my master's student has just interviewed a whole lot of midwives about what do they perceive obstetric violence to be, and how do they intervene, interact, or feel complicit.
Wow, that's interesting.
And that'll be a really interesting paper. But there's so much. The other side of this is obstetric violence or birth trauma or disrespectful care does nobody any good. It's devastating for the mother. It's devastating for the partner often and for the baby in the future. But it's equally devastating for health workers. It destroys trust. It leads to burnout. It makes midwives leave. And we've got huge numbers of midwives who are burnt out and disillusioned by what they have to observe and be a part of. And then when they're a part of it, they feel that they're complicit and therefore they're part of the abuse. And some of them are part of the abuse. Yeah. So the violence, birth trauma, obstetric violence, disrespect and abuse, it's bad for everybody. And we have to measure this in terms of its impact on the economy, on health services, on psychological needs, on the future generations of children. This is really big. And our research that we're just coming to the point of being able to release soon is now looking at models of care that women are in, and then looking at the levels of birth trauma and obstetric violence and all of those other things that happen afterwards. And it's really clear, not to give anything major away, the continuity of midwifery care is massively protective over birth trauma when you control for all the differences in the models. So your model of care is critical.
We need you to do this same research in the UK and in the USA. I mean, is that happening? Are you partnering up with anyone who's asking the same questions in these different places?
We'd love to partner up with someone in the UK. I mean, I've always been mindful that they have got some very good surveys going too, and I we don't want to step on toes there. But we have got the Netherlands has just completed the best survey in the Netherlands, which we're analysing now. Sweden is just commencing it, and Denmark are commencing it. So we would love more people to reach out a hand and say, I'll lead the UK best survey, because we'll give it to you and give you all the support.
Well, maybe if someone's watching or listening, they can get in touch with you about that, because I think that sounds vital, really amazing and important. Thinking about the sort of, the solution-focused part of our conversation, what on earth can we do? I mean, you are a solution-focused woman. That's why I think you're amazing. That's what you're doing. This work that you're doing can be part of the solution. But part of me, and I think probably part of all of us who are involved in the conversation around childbirth, does sometimes feel, I mean, you have moments of despair, don't you? Because you think, well, women have been saying all this. Why should you even have to? When you were talking, I was thinking, why should Hannah even have to do this survey to prove that women are traumatized by childbirth, to prove that they're having these experiences? Because, I mean, I haven't been involved in childbirth for anywhere near as long as you, or anything like the same level. But I've still heard that all of those stories over and over again. And, you know, also I was thinking, how on earth did you manage to go through all that? Because that's one thing I found really difficult about being involved in the childbirth conversation, is having to read all those stories over and over and over. And it's horrible. When you said about the 6,000 responses or something of, you know, the words, I can't remember how you put it, but all those words of trauma, you know, to have to read them, you know, it's so hard. And we know this is happening. And we know it's been happening for decades. And we know that women like you have been trying to make change. And we know that it's still happening. In the UK, we've just had the Care Quality Commission report, which was really damning. And the pandemic is being blamed for making things worse. But we know that it was awful before the pandemic. And the pandemic just legitimized the stripping away of more of what women needed. Sorry, I went on a bit of a rant then.
That's so true. We love to blame everybody, but actually realize we have a problem. And when the obstetric violence paper came out, we were so careful in the media and that to say this is not about obstetricians, this is about healthcare providers. We need to work together to find solutions. And the obstetric response in all of the media was really, well, if only we had better staffing, this wouldn't happen. And I thought, isn't that interesting? That, you know, if you gave us more people, then we wouldn't be nasty to people. Like, you know, I do believe that poor staffing is the worst possible thing for giving quality care. So I'm not dismissing that, but we've got to take ownership. So you asked me, like, what's the solution? So number one, we need it from several prongs. So we need it from women. We need women to keep going. We need women to keep protesting. We need women to go to parliament. We need women to write about it. We need women to get themselves noticed. But we can't just always say women have got to do it. We need legislation. Now in Australia, we do not have a National Human Rights Act. So really there's no teeth. If somebody wants to take a case and they haven't got scars or damage to show, it's really hard to get these cases heard. So we actually need human rights legislation from the top. We need to do co-located multidisciplinary education at university, where midwives, obstetricians, social workers, psychologists get in the same room together and do obstetric violence and trauma-informed care training. So this is what we're lobbying for now. Start at undergraduate level. Let's get it in there. And then we need to get to all of those who are out there already and into a lot of bad habits. And we need to get it recognized enough that health workers have to attend training that really makes sure they understand the implications and you know what needs to be done. Currently, it's really exciting. We have a parliamentarian in New South Wales who, for all things, she's the animal rights activist member. Like, you know, you want, sometimes you get support from the most amazing places, and she's really taken this up. She's asked questions in Parliament. She's now wanting to draft legislation to really address it. So it's not one solution. We keep doing research, women get active, legislation needs to come in, needs to happen in Parliament, needs to happen legally, and it needs to happen at training level. And until we all say we've got a problem, very hard to fix it.
Why are we so bad at understanding what women want and need and listening to women?
So look, there's a big part of me that forgives this, because having worked 20 years in a fragmented system where I was always at the end, where a woman would come into the labour ward and I'd meet her in pain, I'd never known her before. Awful scenario when you're trying to figure out what does someone want and how do you connect with them. Then I left that and I worked 10 years as a private practicing midwife, where I did majority home births, where we had normal birth rates of over 90%, where I just saw the power of a relationship, the power of building trust, not only women trusting us, but what I found is the loss of faith I had in the system. I had almost become scared of everything. Women taught me to trust again, and then I trusted them, they trusted me. It was a wonderful, virtuous cycle. And so we've got to recognize that we've got health professionals in stress situations coming into rooms where they don't even know that person in a stress situation, concerned they're going to be litigated against, you know, concerned that the buck stops with them when it comes to doctors. And in that panic and concern, we do really unfortunate things that are not firstly effective or safe, and lastly very damaging to women. So Relationships make you get to know a woman. They know, you know what she wants. You know she doesn't want a mother-in-law there. You know that, you know, her toddler's having difficulty sleeping. That really worries you. So that in that birthing room, you know so much about how do you tiptoe gently, as I call it, amongst the debris that women have, that they bring in their lives to birth. And in that sensitivity, when things go wrong, informed consent occurs. And then afterwards, that same midwife can spend the next 6 weeks checking in, hearing the stories, checking whether or not extra help needs to be. And so there's that debriefing, processing. What we currently do with majority of our care in Australia is women see different providers all the time. They come in and birth with a complete stranger, maybe have 3 or 4 changeovers with a first-time mum. They might have 2 days in the postnatal ward. If they're lucky, many of them might get 3 or 4 visits at home from postnatal care, and then see you later. And they're very lucky to get anything after 2 weeks. And you're left, often for women, they haven't processed it. They haven't had time to think about it. They're holding a baby. They're sleepless. They're, you know, I should be in love. And then it starts to brew. And 6 to 8 weeks afterwards, man, it all starts to come out.
Yeah, I think postnatal care, I mean, we haven't really talked much about that today, but that's another massive, you know, piece of the puzzle, isn't it? In terms of, you know, I talk to so many women who sort of get in touch with me saying, this happened to me when I had my baby. Was it the right, I can't stop thinking about it. Should they have done that? Or should they not have done that? Should I have said no? Or should I have not consented? Or should I put it in my birth plan? You know, they're going over and over and over that moment. The system isn't. But
no, and we found so many women when we asked that question, did you complain? Did you think about it? Would you have liked to? So many women didn't know they actually could.
Yeah.
So thank goodness we now have some great organizations that women can go to, human rights organizations, you know, counseling organizations, etc., that can really start to help advocate for women's voices.
But also to have that relationship-based care that you talk about, that then comes past the birth, you know. And again, it's like the healthy baby is all that matters thing, isn't it? It's like, well, you've had the baby now, so you don't need anything else. But even after a complicated, difficult birth, to have someone there who, you know, like you say, afterwards, who you can talk to about it. You wouldn't have to be emailing people like me, a total stranger, to say, should this have happened to me or not? You would have been able to have that conversation with somebody that you've got that eye connection with, that link, that soul to soul. You know, they were there when you were in your most intimate birthing moment. So you build a connection in that moment, don't you? That's so precious. And we're just kind of throwing that away, aren't we?
If it all works really well and you come back for your next baby, you'll get the same midwife if it all works well, and you'll go through a labor and birth that is tiptoes amongst, again, the debris, and really does everything to carve out what was perhaps missing or problematic in that first birth. And, you know, you've got the wonderful Jill Thompson in the UK who writes about redemptive birth. So trauma is not the end of the story. You know, like all bad things that happen in life, we have the opportunity to turn the wound to gold, as Rumi says. So how do we turn the wound to gold? First, let's stop the wound.
Yeah.
There are going to be wounds. Let's do that safely when it happens. And then let's turn the wound to gold and help women to do that.
Hannah, it's been amazing talking to you. Before we finish, could you just give a little bit of advice to anyone listening to this who is pregnant, who's thinking, what can I do? I know you said quite rightly, it shouldn't all be on women, but I know this is something that pregnant women, you know, will listen to a podcast like this and think, oh, you know, what can I do? So what would you say to them?
So, for example, in the UK, you contact your human rights organisations, your maternity advocacy groups. You can contact your local MP if you really think it's serious enough that you do want to do it. You can write to your hospital and ask for a meeting with them, and ask to look at your notes, and ask to have an explanation. So, you know, do not stay there in it. Talk to someone, and there's more. Go online, look up birth trauma. Go online, you know, get connected to mothers groups that are really. You know, that's what was so wonderful about your positive birthing mothers movement, groups, because it enabled people to share, but it also moved on to strength. It was a strength based as well, and a positive thing. And we need to do that. We need to move out of the trauma. It's really important we don't continue to repeat the trauma. But there's so many groups now available.
And is there anything that a woman can do who hasn't had a baby yet, who's maybe listening to this pregnant, to take control of her birth and try and have a positive experience?
Please do your research. If you bought a microwave or a fridge, you would look at the star rating and a whole bunch of things. Do not walk in with one of the most important experiences of your life and just think anything you get is going to be the same. Research, advocate, and do it early, because many of the good models of care sadly book out very early, because once women know, they're all in demand.
Hannah, it's been amazing talking to you. Thank you so much for taking the time today. I think you are the gold in the wound, and I appreciate your existence on this planet more than you will ever know. So thank you so much.
Right back at you, Millie.